Welcome to the first of two videos about coordinated entry in the Texas Balance of State Continuum of Care. This first video reviews how ending homelessness is possible and introduces a continuum of care and coordinated entry. In this video, I discuss homelessness as a complex social problem and define ending homelessness. Then I will go into detail by defining and discussing a continuum of care and coordinated entry at a high level. First, homelessness is a complex social problem. It evolves constantly, yet our responses remain fragmented or unable to adapt. The result continues to be a sizable gap between high spending and poor outcomes. What do I mean when I say complex social problem? There are key characteristics of complex social problems. First, there are multiple actors involved. Various institutions own pieces of the problem, but no one is responsible for the whole picture. Second, there is a lack of urgency. The problem has persisted for so long that it feels normal. As a result, there's little incentive to approach it differently. Next, there is a high public cost. The problem is expensive and taxpayers bear the cost of responding to it. There's also a negative user experience. People in need have a difficult time navigating available resources. There's also changing information. The problem has moving parts, and new realities emerge constantly. And lastly, there are poor outcomes. Despite heavy taxpayer spending, existing responses do little to solve the problem in the long term. Complex social problems don't demand new programs or more bureaucracy. Instead, they require a flexibility and adaptability in the process. When we think about ending homelessness, we don't mean that we won't see people experiencing homelessness again. Changing economic realities, the unpredictability of life, and unsafe or unwelcoming family environments may create situations where individuals, families, or youth could experience or be at risk of homelessness. It would take major structural changes to truly end homelessness for all individuals. The U.S. Interagency Council on Homelessness states that ending homelessness means every community has a systematic response in place that ensures homelessness is prevented whenever possible, or is otherwise a rare, brief, and non-recurring experience. Specifically, every community will have the capacity to quickly identify and engage people at risk of and experiencing homelessness, intervene to prevent people from losing their housing and divert people from entering the homelessness services system, provide people with immediate access to shelter and crisis services without barriers to entry if homelessness does occur, and quickly connect people experiencing homelessness to housing assistance and services tailored to their unique needs and strengths to help them achieve and maintain stable housing. So how exactly is this being done? Who is involved? It begins with the establishment of a continuum of care. A continuum of care is a term that's often used in the healthcare system. It describes an integrated system of care that guides and tracks patients over time through a comprehensive array of health services spanning all levels of intensity of care. In the context of ending homelessness, a continuum of care is not that different and goes even further to include the planning aspects that are essential to a continuum of care. According to the Department of Housing and Urban Development, a continuum of care is a group organized to carry out the responsibilities of the Continuum of Care, or CoC, Program Interim Rule. This was first published and became effective in 2012. In addition, various organizations are involved in a continuum of care, from homeless service providers to mental health agencies, from universities to governments and businesses. Currently, there are over 400 continuums of care across the country. In Texas, there are 11 continuums of care, of which the Balance of State is 1. There are 4 main responsibilities of a Continuum of Care, or CoC. First, a CoC must operate the CoC, and this includes operating a board and engaging with members. Second, a CoC must operate a Homeless Management Information System, or HMIS. Third, a CoC must plan. This includes coordinating the implementation of a housing and service system and conducting an annual point-in-time count, for example. And lastly, a Continuum of Care must design and operate a collaborative process to prepare an application for Continuum of Care program funding. And in this video, I focus on the planning activities of the Texas Balance of State Continuum of Care, specifically establishing and operating a coordinated entry system. What is coordinated entry? According to the U.S. Interagency Council on Homelessness, coordinated entry is a process through which people at risk or experiencing homelessness can access resources in the housing crisis response system in a streamlined way, have their strengths and needs quickly assessed using a standardized assessment tool and practices, are referred to appropriate housing and mainstream services tailored to their needs, while the most intensive interventions are prioritized for those with the highest needs. In this definition, you'll see that there are 4 words that are underlined. I've underlined them because they represent the 4 core elements of a coordinated entry system: access, assessment, referral, and prioritization. You can think of coordinated entry as an emergency room. People experiencing all types of crises can come into an emergency room, and we must triage and assess them so that we understand their situation. We then refer them to services that fit their needs and prioritize our work so that we are addressing people with the highest needs first. For example, we'll have to assess and treat someone with a broken toe much differently than someone who is having a heart attack. Next, I'm going to dive into the history of coordinated entry and how it came about. In 2007, U.S. Congress appropriated $23.75 million to fund the Rapid Rehousing for Homeless Families demonstration program. 2 years after that, the Homeless Emergency Assistance and Rapid Transition to Housing, or HERTH Act, was signed into law and created the Continuum of Care program. At the same time, 23 communities were funded for the Rapid Rehousing for Homeless Families demonstration program for 3-year grants. One eligibility criteria for applicants was that the community had to demonstrate that they had a central intake process for identifying and screening homeless families and that they would use a single assessment tool. Moving forward to 2012, the Continuum of Care program interim rule was published, and it stated that each Continuum of Care must establish and operate a centralized or coordinated assessment system. Then, in 2016, an evaluation report was published about the Rapid Rehousing for Homeless Families demonstration program. The report found that there were 2 groups of implementation approaches among communities: centralized and decentralized intake. Communities using a centralized approach were working to answer the question, what housing and service assistance is best for this family of the several that we have to offer? On the other hand, those using a decentralized approach were answering the question, should we accept this family into our program? They also found that study participants in communities with centralized intake structures became homeless less often than those in communities with decentralized intake systems, although without statistical significance. In 2017, HUD published a notice that Continuums of Care must establish and update its coordinated entry process in accordance to that notice by 2018. It also identified Continuum of Care and Emergency Solutions Grant program recipients as required participants of the Continuum of Care's coordinated entry process. We walked through the history and timeline of coordinated entry to provide you a better picture of how it came to be. And as you can see, coordinated entry is a relatively new concept and continues to be something that all communities are working to implement and improve every day. What is the purpose of coordinated entry? Coordinated entry is a way of structuring a continuum of care's systems of care so that it fits together intentionally and efficiently. This will result in more efficient use of resources, improving fairness and ease of access to resources, including mainstream resources, and prioritizing people who are in most need of assistance. Coordinated entry changes a continuum of care from a project-focused system to a person-centric system. This means using a systems change approach. Historically, the system has worked by asking the question, should we accept this household into our program? This question is very similar to the findings in the evaluation report I spoke about earlier. We have focused our attention on programs, which means we often have unique forms and assessment processes catered to each organization. We may also have uneven knowledge about available services and housing interventions. With coordinated entry, the system shifts and focuses on what housing and/or services quickly ends this household's homelessness permanently. This means the approach is client-centric. As a community, all programs are using standard forms and assessment processes for every household. This also means that information about available services and housing interventions are more accessible, and different organizations are coordinating and collaborating based on the strengths of their programs and services. Now that we have an idea of what coordinated entry is, its history and purpose, how does it work? As I stated earlier, there are 4 core elements of coordinated entry: access, assessment, referral, and prioritization. Access refers to how people experiencing a housing crisis learn that coordinated entry exists and access crisis response services. The first contact that most people experiencing a housing crisis will have with the crisis response system is through an entry point. Entry points play a critical role in engaging people in order to address their most immediate needs through referral to emergency services. Entry points also play a critical role in beginning to determine through an assessment which intervention might be the most appropriate to rapidly connect those people to housing. Next, I'll talk more about the assessment. This refers to the process of gathering information about a person entering the crisis response system. It includes documenting information about the barriers the person faces to being rapidly housed and any characteristics that might make them more vulnerable while homeless. The assessment also collects information to identify a person's needs, preferences, and immediate needs and connect them to appropriate interventions. The next component is referral. This is the process of connecting people to resources for their immediate needs and to housing and supportive services projects. It involves screening for eligibility. The purpose here is to match a person to housing they are likely qualified for, rather than predetermining their eligibility. In addition, it involves the community coming together to form a participating project list to know and understand all the resources available. The last core element is prioritization. Prioritization is the process by which all people are ranked in order of priority. The purpose here is to ensure that people with the highest priority of need are offered housing and supportive services first. The person's level of vulnerability or need is determined by analyzing the information obtained from the assessment against the Continuum of Care's prioritization standards. In the final series of the coordinated entry theory videos, I will go into detail about the prioritization standards for our Continuum of Care. When a continuum of care establishes and operates a coordinated entry system, there will be benefits for all who are involved. First, for people at risk of or experiencing homelessness, they're able to locate housing or services they need faster, be referred only to projects that they are likely eligible for, get access to projects once referred, and appeal rejections by projects through a transparent procedure. Housing and supportive projects are able to avoid inappropriate or ineligible referrals for their projects, better manage prospective project participants through a centralized prioritization list, and comply with program requirements. Public and private funders are able to be confident that housing and supportive services projects are serving the intended people. They can see increased compliance with eligibility requirements, have access to better data for system and project planning, and experience improved reporting. And lastly, Continuum of Care or homeless system planners are able to identify areas for improvement, comply with program requirements, improve fair access and ease of access to resources, improve data for system and project planning and resource allocation, and standardize understanding of who will be served. A lot of high-level information was provided during this video, and I hope you take away 4 key things. First, homelessness is a complex social problem, and ending homelessness is possible when it involves communities having a systematic response. A continuum of care provides a structure for communities to plan for ending homelessness. And more specifically, coordinated entry provides a structure for a continuum of care to identify and engage with people experiencing homelessness and prioritize resources. Thank you for watching one of 2 videos about coordinated entry. If you or your agency is interested in participating in a local coordinated entry process, please contact the Systems Change team at ce@thn.org. There is a separate and formal training process for staff members involved in a local coordinated entry process.